Now I'm going to go through some different scenarios. And what I want to talk through is what you can do as a doula to help mom through what to expect, what kind of care she might receive, give you guys as much information as I can from the healthcare perspective, and make sure you know what you can do as a doula to help a mom in these scenarios. If your client goes into labor before 36 weeks, we separate pregnancy into 3 trimesters. However, we determine if a baby is going to survive well based on how term we consider them, like a piece of fruit. A baby that is 36 weeks and below is considered preterm. When that clock strikes midnight and they hit 37 weeks, they're now considered term. When they hit 42 weeks, the moment midnight hits, they would be considered post term. Post dates is when a client is just after their delivery date. So if you're 40 and 1 or 40 and 4, that means 40 weeks and 4 days gestation. You are post dates, but you are not post term. Post term is when you get past 42 weeks. The majority of our stillbirths happen post term. Preterm is going to be 36 weeks and before. When a baby is preterm, mom's going to go into labor early. And when she gets admitted into the hospital and we determine that she is actively in labor, they're going to want to give her steroids to help the baby's lungs. So we'll give mom a series of shots of betamethasone, which is a steroid, to help the baby's lungs mature. The fear of a preterm baby is not so much that they don't have all of the organs, it's that their organs aren't yet fully matured, especially their lungs. The lungs do the most significant portion of their growing in those final weeks of development. When a baby is born preterm and goes to the NICU, we're keeping them stable so that their lungs and the rest of those tissues can mature as though they were still inside mom's belly. So when a mom delivers preterm, we do what's called anticipatory guidance, where we get as much information as we can about what's going on with baby, what mom can expect. If she is delivering before 20 weeks gestation, that is not considered a viable pregnancy. If we're at 20 weeks gestation or at 3,500 grams of weight, a baby is considered human remains. I'm not trying to get political or legal here. It's just whether or not I have to call the coroner and whether or not we have to go through with a funeral. If mom is 19 weeks and 6 days and we deliver baby, that baby is not going to survive outside of the womb. Mom has the opportunity to bury the baby, or even at 19 weeks and 6 days, the baby could be considered products of conception and disposed of with the medical trash. If mom is in early labor, it matters how early she is. If she is 32 weeks or after, we usually have really good outcomes for our babies. They're going to head to the NICU. However, they're likely not going to be there for more than a month or two. That being said, 32 weeks and after is usually when we anticipate those preterm babies to have pretty good outcomes. The better the outcome likelihood. So 34 weeks is better than 32 weeks. 36 weeks is better than 34 weeks. 38 weeks is better than 36 weeks. 40 weeks is our ideal, right? Or whenever baby's ready to come out around the 40-week time. So if mom is in preterm labor, anticipate that she's going to get the steroid shot for baby's lung development. She's going to have to meet with the NICU staff, the pediatrician, and their neonatologist. She's likely also going to have to meet with maternal fetal medicine doctors. So when a mom has preterm labor and delivers preterm, there's a lot that's going to be focused on baby, and mom often really gets neglected. First person to neglect herself because she is so worried about her baby as well. When your mom has a preterm baby, make sure that you are focusing on her mental health, on her stability, that she's eating, drinking, and resting, especially because moms whose babies go to the NICU don't get to have that immediate, precious, special bonding time. We make all this effort to make birth so special. When we have preterm births, we still want to do what we can to make labor and birth special. But now we have to anticipate that the baby will go to the NICU. There are some different ways that we can help support mom when she's got a baby in the NICU. One of my favorite things to do is get a series of blankets on rotation, one with the mom and one with the baby. While mom's in labor, have a blanket under her gown or shirt, getting all of her smell. When baby's born and goes to the NICU, we want baby to be wrapped in the blanket, covered in mom scent. Unless baby has to be in a sterile environment, we ideally want the blanket with mom's smell all over baby. Then put a second blanket on mom so that when mom visits the baby, we can switch them out. And that's so that mom can start to smell baby, baby can start to smell mom. Smell is where the majority of your memories are connected into your olfactory nerve. So when you smell fresh baked cookies or your mom's lasagna, it brings back that rush of memory. Smell is very important for letting us know that we are safe, that we're in a space conducive to our wellness and well-being. Being able to smell mama is going to make that baby feel safer. Being able to smell baby is going to make that mom feel more bonded and connected to that baby, even while the baby's in the NICU. Having mom know when she can and cannot go into the NICU, knowing how often she can visit, knowing what their breastfeeding supports are, asking to be involved in feeding, getting pictures, getting updates. These are all things that we're going to go through with mom in that anticipatory guidance when we're preparing for preterm birth. If mom goes into labor early and there's nothing we can do to stop it, keep in mind that if baby's going in the NICU, you want to be able to help focus on mom because everyone else, the family, et cetera, is going to be focused on baby. The other thing you have to prepare for when you have a preterm baby is that the house is likely not ready. The family is likely not ready. So just the same way that baby wasn't cooked, neither is anything else. Moms that have preterm babies may or may not have had their baby shower yet. They might not even have a stroller or a car seat or their room painted. They might not have diapers or wipes or anything for that baby. When you have a preterm mom, we need to make sure that her nest is ready. Because if she delivers at 32 weeks, her baby might stay in the NICU for 3 to 4 weeks, but that's still going to be baby coming home sooner than she had anticipated, sooner than she had time to get her house ready. And once the baby was delivered, it was in the NICU. It's not like mom's going to have all this time to get her house ready or feed her other kids. So this is a great opportunity to set up a meal train, get her community or her church parish or whoever else is in her nest involved in her care. With preterm labor, a lot of your care is trying to make up for the lost time because you don't get that time when you have an early baby. I want to talk to you next about inductions and some medical reasons that you might have an induction. The most common reasons for having a medical induction is usually going to be because mom's got elevated blood pressure and we're worried about preeclampsia. If she has signs and symptoms of preeclampsia, HELP syndrome, if she has elevated liver enzymes that could indicate something called cholestasis, which can result in calcification of the placenta, but it can also result in liver damage to mom that could potentially be irreversible. But the increase in those liver enzymes can be absolutely fatal to the baby. So if mom has elevated liver enzymes, she'll indicate that she's really itchy. She might look a little yellow or jaundiced in the skin or in the eyes. That would be a great reason to induce. So anytime that mom or baby would be medically better with them being separated, those are the times that we want to induce. If mom is already in labor and we get to the hospital, a lot of times labor is going to slow down. You'll be at home, mom's contractions are coming every 3 to 4 minutes. They're strong, lasting at least a minute. You've been at home for the last 3 hours and we're like, wow, this baby's going to be coming soon. We get to the hospital and it's been 15 minutes without a contraction, or the last contraction she had was really minor. Part of that is because she's moved from one area to the other, so she's not in her nest. She's not in her safe space to have a baby. So she's going to have to readjust to that labor space. A lot of times when moms come into the labor and delivery unit and they're in early labor, 3-4 centimeters, labor slows down because they've come to the hospital. This is one of the reasons that we encourage hospitals to use the 6 centimeter active labor admit, so that if a mom is less than 6 centimeters, we send her home. We're not sending her home because we don't believe that she's in labor. We're not sending her home because we think that she's lying to us or she's done something wrong. We're sending her home because she's more likely to progress in a healthier and safer way at home than at the hospital. So if mom goes to the hospital and she's 3 centimeters dilated and she goes home, great. A lot of times moms will get sent home. They're so comfortable at home, labor picks right back up and then we can't stop it. They come right back in and we have a baby. A lot of times that happens, and I think it's because we sent mom home. It allowed her body to be like, oh, wait, this is the place where I birth. So if I go to the place where I birth and I don't deliver and then I leave, my body's like, wait, that's where I'm supposed to birth? Let's go back. so your body can feel a little safer in that space the second time you're there. This is also why I think it's really important that you get a tour of the labor and delivery unit and see what the hospital's rooms look like. If mom is already in labor and things slow down, we might augment her labor. Augmentation is when you take something that's already started and you're going to adjust or change it. We're changing them, we're augmenting them. If mom is in labor and we're going to augment it, we're going to speed it up, make the contractions come harder or faster, more frequently, have a better rhythm. We either give Pitocin. She could get Cytodec either under the tongue, in the vagina, or rectally. We could use a Foley balloon, which is a catheter with two little balloon spaces that you can inflate. Once the balloons are inflated, they will manually mash on the cervix, helping to open it up and dilate it early on. That's a way you can induce or augment labor. The most common way I've seen labor augmented is through artificial rupture of membranes. So mom comes into labor, she's progressing well. She could be 8 centimeters, but if her water bag is still intact, the physician will likely rupture her membranes and then baby comes out shortly after. There's not necessarily a reason to rupture the bag of waters unless I'm trying to induce mom. Let's say mom has preeclampsia and we're inducing her because we don't want her blood pressure to get too high and her to have a stroke and die. That would be a problem. So we're inducing mom, and if her blood pressure starts to get higher every time she has a contraction, then it's going to be really important that I do what I can to help lower her blood pressure, lower her heart rate with comfort measures. It also might be a really great time to use an epidural. If mom's having really uncontrolled blood pressures, being anesthetized from the waist down and being able to sleep and calm down might be exactly what she needs for her blood pressure. I've seen other women who have elevated blood pressure handle contractions, get an epidural, and their blood pressure skyrockets. It's a tool that can be used either time, and you just have to take it moment by moment, which is why the decision trees are so important, so that you can start thinking through what comes next, what could happen. So artificial rupture of membranes is probably the most common intervention and is usually what starts the cascade. We'll go ahead and rupture her membranes, then start a little Pitocin, then get an epidural, place an internal uterine pressure catheter, and then go from there. Some moms will complain of back labor, which is often caused because the baby is what's called OP, or sunny side up. Baby is facing up, and the back of baby's head is pushing directly onto mom's sacrum. There are a bunch of nerve endings that go through here. If the hard part of baby's head is grinding on mom's spinal cord, it will cause significant pain. One of the ways to help relieve that is through counter pressure, by applying counter pressure to the back of the sacrum. But also what you can do is flip mom to her hands and knees. Now gravity's bringing baby down to the belly and off of the spinal cord and off of the back. So if mom's got back labor, that can help. Another reason mom might have back labor is the baby could, instead of being sunny side up, might be asynclitic. Asynclitic is when the baby's head position is off, preventing them from getting into a good position down into the birth canal. When their head is off, it pushes on bones, ligaments, tendons, muscles, nerve endings, and causes pain. Having mom rotate from her side to the other side, lift one leg up, do a Captain Morgan's or some deep squats can help get the baby into a better position and hopefully relieve some of the pain causing back labor. Prolonged labor is difficult to measure because different hospitals have different policies on what is considered prolonged labor. If we have a rupture of membranes for more than 18 hours, it's considered a prolonged rupture of membranes. The water bag has been open and exposed to the environment for more than 18 hours, increasing the risk for infection. That's when we might start augmenting her labor to speed things along because we don't want an infection to develop, which could hurt mom or baby significantly. We could use nipple stimulation, or if mom's in the tub and her labor is slowing down, get her out of the tub. If mom is on the ball and labor starts slowing down, get her off the ball. If mom is in bed and labor starts to slow down, get her out of bed. Whenever labor starts to slow down, try something new. When mom does have prolonged labor, she's going to get exhausted, and you're going to have to fight with a mom that starts to get hangry. She's going to get grumpy, irritable, and you have to remember that you're preparing mom not only for labor and birth, but for that immediate postpartum period. So if she's having days of labor, keep in mind that your care for her in that immediate postpartum period is going to be more significant, especially in the first few weeks following labor, because she's exhausted herself so much throughout her labor and birth. So she's just done a marathon of work and now she has to take care of a newborn. A rapid birth is a precipitous birth, and this is when labor and delivery happen in less than 2 hours. Our concerns of the precipitous birth include the risk of baby hitting the floor. If baby gets delivered in the car or at home and there's an issue, we don't have our medical team there to help. Another potential issue is that baby might not get their lungs squeezed tight enough to get rid of all the mucus. So they might have a little bit of what's called transient tachypnea, where they're breathing a little bit faster during that transition period. Precipitous birth can also be associated with hemorrhaging, losing a lot of blood after labor. The idea is that the uterus didn't have enough time for the Pitocin to cause hard enough contractions to stay contracted. If you're ever with a client who all of a sudden delivers a baby, the thing you need to know is to call 911, dry and stimulate. Don't touch the cord. Don't try to deliver the placenta. Put the baby on mommy's chest, get a towel and dry the baby off and stimulate them. That's what you do. And you call 911. The 911 operative will take you through the rest of their care and will help you through anything else that you need to do. But if you're worried, all you got to do is pick the baby up off the floor, put it on mom's chest, dry them off with a towel. That's your job in case of a precipitous birth. If the baby is breech or has another malpresentation and the physician will not deliver the baby in that position vaginally, mom will likely have to have a cesarean section. There are some physicians in Louisiana who will offer breech delivery, but you might have to travel to actually see them, and that might not be realistic for your client. Most physicians in the Louisiana area, if the baby is breech or transverse, are likely going to encourage mom to have a C-section and will not entertain the idea of a vaginal breech birth. However, there are things we can do. There's an organization called Spinning Babies, which getting babies into the optimal position, having mom do inversions, putting ice packs on the top of her belly while she's sitting in a warm tub, having her lay down on her side with her head lower than her body. What we could do is an external cephalic version. An external cephalic version is when you're going to go into the hospital, baby is in mommy's belly, and baby's head is facing the wrong way. Baby is breech. When we do an external cephalic version, what that means is externally outside of the body, I'm going to move the baby's head cephalic and invert it, that's the version, to try and get baby's head down. A midwife, a physician, a nurse are going to work together to physically manipulate the baby while it's in mommy's tummy to get the baby head down. There are risks associated with an external cephalic version. You can have placental abruption, where the placenta tears away from the uterus. You can have a uterine rupture. Baby could not tolerate all of that pushing and pulling and start having decelerations in their heart rate, and that turn into an emergency C-section. Whenever we do an external cephalic version, we make sure that we do it on the labor and delivery unit with an OR prepped and ready to go, just in case the worst happens. When an external cephalic version is successful, when that mom comes in to deliver, they might still do an ultrasound at the bedside just to confirm that baby didn't go back into the other position. If mom is pushing baby and is too tired to push that baby out, if she's had a really prolonged labor, if she's been pushing for 2 hours and she was in labor for 48 hours and she just doesn't have anything left, but there's space in her pelvis, she just needs a little help, that's when we can use forceps or a vacuum extractor, or in certain cases, they might do an episiotomy. Episiotomies are not nearly as common as they used to be because they're not effective. This is the perineum, and here's the vagina. If I were going to cut an episiotomy, I would be tearing through not only this muscle, but into this muscle as well. And this muscle is connected to your bowels. If I can cut into the muscles that are getting into the bowel tissue, then I'm putting mom at a huge increased risk for infection, because there's now fecal material that's right next to her vagina, connected to her cervix, connected to her uterus, which just had all of those open blood vessels from the placenta that just detached from it. So if I were to cut or to tear and to rip into that rectal tissue, I'm exposing fecal matter to open wounds, and that can be really dangerous. So if mom has a 3rd or 4th degree tear, or if they do an episiotomy, if they cut these tissues, then they are likely going to give her antibiotics as a preventative safety measure because of the exposure of that fecal material to all of those open wounds that are fresh from labor and birth. So those are our operative births and the times that we might use them. Physicians are usually either going to use forceps or a vacuum. They're not going to use both, and they're usually trained in one and not the other, or they feel more comfortable in one and not the other. There's one physician I know at the Baton Rouge General who is a whiz at forceps. She pulls those things out and those babies slip out. It's amazing. But the rest of them I know prefer to use the vacuums. So those are some different scenarios that you might encounter as a doula.